Elena is a 25-year-old woman who just graduated university with a degree in nursing. She is not currently taking any medication and does not use substances. She was referred because her colleagues noticed that she was doing longer shifts than usual, sometimes going over 24 to 36 hours and refusing to take breaks because she, quote, needs to save the patients. She indicated that she could perform surgery and attempted to prescribe medication even though she is not a doctor. Elena had been taken off rotations because of the risk associated with sleep deprivation and erratic behavior. When Elena attends her first session, she seems to be extremely tired, walks slowly, speaks in a very slow voice, and mentions how she doesn't have any reason to get up in the morning. Her older sister Lucero is present at intake and mentions how, starting in her teens, she has seen Elena have strange periods of extremely high energy that may last for a week or more. In these moments, she does not consider consequences and makes haphazard plans. For example, she once made a group chat with all her contacts because she needed their support in running for mayor, but she had never been interested in politics before. She lost several friends after this episode. Also, Elena is currently staying with Lucero as Elena was unable to afford her rent payments and was evicted from her apartment. Lucero mentions that after these periods, Elena then enters a phase of darkness where she seems to lose hope, sleeps for several days, doesn't shower or eat, and refuses to talk to anyone. She indicates that there are also times when Elena seems to be her regular self, but they don't really know when she might shift and would like to get an assessment to understand her better. In addition, Elena is adopted and Lucero does not have any information on her biological parents.
So now let's talk about what is bipolar disorder. According to American Psychiatric Association, bipolar disorder is a serious mental illness in which common emotions become intensely and often unpredictably magnified. Individuals with bipolar disorders can quickly swing from extremes of happiness, energy, and clarity to sadness, fatigue, and confusion. These shifts can be so devastating that individuals may consider suicide. All people with bipolar disorders have manic episodes, abnormally elevated or irritable moods that last at least a week and impair functioning, but not all become depressed. So next, let's talk about different types of bipolar disorders. Bipolar 1 disorder is characterized by manic or mixed episodes with or without depression. Bipolar 2 disorder involves episodes of hypomania and depression. Another type called cyclothymic disorder involves depressive and hypomanic symptoms that cause impairment but do not meet the severity or duration criteria for bipolar 1 or 2. Other specified bipolar and related disorder describes patients with episodes mood symptoms who do not meet the criteria for the other three disorders.
So we thought it would be interesting to see if there was actually some background on assessing bipolar disorder, and there is some interesting background. In the early 20th century, assessing patients to begin with was through what they've been calling descriptive psychiatry. Emil Kraepelin was the first to distinguish between some illnesses based on symptoms. So he distinguished manic depressive illness from dementia praecox, which is now schizophrenia, laying the foundation for bipolar disorder classification. Diagnosis at the time in the early 20th century was phenomenological. It was based on clinician judgment and direct observation of mood episodes of mania, depression, or mixed states. So in the 1950s through the 1980s, we see the rise of standardized clinical tools. Structured diagnostic tools emerged alongside the DSM-1 to the DSM-3. The Hamilton Depression Rating Scale and the Young Mania Rating Scale began clinical adoption to quantify symptom severity during this period. The SCID, Structured Clinical Interview for DSM Disorders, became a gold standard for diagnosis. In the 1990s through the 2000s, there was some refinement and specificity. Tools like the Mood Disorder Questionnaire and the Bipolar Spectrum Diagnostic Scale were developed for screening in both clinical and primary care settings. Researchers began differentiating bipolar 1 and 2, leading to the inclusion of bipolar 2 in the DSM-4 in 1994. Development of longitudinal tracking methods like mood charts and life chart methodology helped capture cyclicity. We see the emergence of digital and biomarker integration, like mobile apps and digital health platforms are now used to monitor mood and adherence, while EEG, neuroimaging, and digital phenotyping are emerging tools for pattern recognition and relapse prediction. Newer approaches are beginning to integrate natural language processing and acoustic markers to detect mood shifts. This is our recommended assessment, the MDQ, the Mood Disorder Questionnaire. It has positive activation, items 3, 4, 8, and 9, that assess increased energy and activity, grandiosity, and decreased need for sleep. Individuals endorsing symptoms defining positive activation are not likely to report significant levels of negative affect and are likely to be energetic and extroverted. Individuals scoring high on positive activation may be less likely to rate their symptoms as impairing, given that increased levels of energy and activity may be experienced as advantageous to some degree, especially if they are mild in nature. Mild mania can be fun, right? This factor is strongly associated with a BD diagnosis. Now, there are negative activation items, 1, 2, 6, 7, 12, and 13, that assess irritability, racing thoughts, levels of negative affectivity, and distractibility. This factor is strongly associated with BD, as well as a range of other disorders, many of them, like depressive disorders, PD, PTSD, GAD, substance use disorders, are characterized by emotional dysregulation and or transdiagnostic personality traits such as neuroticism and disinhibition. Clients high in negative activation may be at risk for engaging in impulsive behavior in emotional situations.
We chose to use the Mood Disorder Questionnaire because its relevance to our disorder of interest, specifically bipolar type 1. We liked this assessment because it's a self-report measure, and thus it's easy for most clients to use in the screening process. Clients are presented with a statement and are prompted to select either yes or no responses, depending on whether the statement applies. Bipolar disorders are distinct from depressive mood disorders by the presence of manic episodes. This brief assessment screens for the existence and severity of manic symptoms and behaviors. One important thing to note, though, is that this tool is intended for use as a preliminary screening for manic depressive and bipolar disorders. It is not designed as a comprehensive diagnostic tool. So in order to get something more comprehensive, you would want to use a longer assessment.
So we thought it would be worthwhile to test the worthiness. So with regard to purpose, the MDQ is designed to screen for bipolar spectrum disorders, especially bipolar 1, as Hannah said, by identifying clusters of manic and hypomanic symptoms. With regard to format, it's an easy to administer screening with diagnostic relevance, which leads to practicality. The MDQ includes 13 yes/no items that assess manic symptoms, followed by 2 additional questions that address whether the symptoms occurred together and the degree of functional impairment. While originally validated for adults, adapted versions are available for adolescents, making the tool versatile across age groups. With regard to internal consistency, with a Cronbach's alpha of 0.90, the MDQ shows excellent internal consistency, indicating that the items work well together. They reliably measure the same construct. So with an alpha of 0.90, that's excellent. With regard to test-retest reliability for the MDQ, the reliability is 0.79 over 1 week, suggesting good temporal stability and that the results are consistent over short periods. With regard to criterion validity, or how well a test predicts outcomes based on an external benchmark or gold standard, This test shows strong agreement with SCID diagnosis. With regard to construct validity, which is how well a test measures the theoretical concept it's intended to, the test shows strong agreement with manic symptom measures. And with regard to sensitivity, the ability of a test to correctly identify those with the condition, true positives, high sensitivity equals few false negatives, and specificity, the ability of a test to correctly identify those with the condition, true negatives, there again is high specificity, which equals few false positives. The range of scores, expressed as proportions or percentages of correct identification, are 0.9 to 1, excellent, 0.8 to 89, good, 0.7 to 79, fair and acceptable, and here we see scores between 0.72 and 0.91. So I believe we talked about how sensitivity in primary care might be hard to peg because of a number of factors. There may be a low prevalence of cases in primary care, atypical or subthreshold symptom presentation, prioritization of specificity over sensitivity to avoid false positives and overdiagnosing, and report limitations that lead to underreporting. So patients may be less aware of manic symptoms or underreport them due to stigma or misunderstanding. So let's talk about assessment administration. The MBQ screens for a lifetime history of manic, hypomanic symptoms, helping identify possible bipolar spectrum disorders, especially bipolar 1 and 2. So there are a variety of options. The self-administered option, which is on paper, the client completes in the waiting room, at home, or during intake paperwork. It's best for standard practices in clinics and easy for intake packets. The self-administered option is digital. The client fills it out via secure online forms or on a tablet or iPad. It's best for telehealth and tech-friendly offices. There's the clinician-administered option, which is interview style. The clinician reads items aloud and records responses. It's best for clients with literacy, cognitive, or language barriers, older adults, or when clarifying complex symptoms. The instructions we give clients are, quote, the following questions ask about a period in your life when you've experienced certain mood states or behaviors. Please answer yes or no to each. After that, there are 2 follow-up questions about how these experiences occurred together and whether they caused problems in your life, unquote. So the structure of the MBQ is as such. There's a symptom checklist, 13 yes or no items. For example, have you ever had a period when you felt so good or hyper that other people thought you were not your normal self? And the co-occurrence question. If you checked yes to more than one of the above, did several occur during the same period of time? And then the fundamental impairment question. How much of a problem do these experiences cause you? No problem, minor problem, moderate problem, or serious problem? The scoring criteria are original cutoffs. It's a positive screen if there are more than or equal to 7 symptoms that are endorsed as yes, occurred at the same time, caused moderate to serious problems, and we get to adjust our interpretation depending on the setting. For example, stricter thresholds in a primary care due to lower sensitivity. And we're offered some valuable clinical tips for administration. So emphasize lifetime perspective, not just recent symptoms. Normalize the experience. So we say, some people have experienced these symptoms at various points in life. It doesn't necessarily mean you have the diagnosis. If time permits, we explore some yes responses with concrete examples to reduce misinterpretation.
Evidence-based treatment for bipolar 1, if you have a client like Elena that you suspect has bipolar, one, we recommend to refer to a primary care physician because there are a lot of physical causes that could mimic the symptoms of bipolar 1, such as neurological or endocrine diseases. We'd also recommend a referral to a psychiatrist for not only pharmacotherapy, but ongoing health monitoring, as medication combined with psychotherapy is considered the first-line treatment for bipolar disorder. When we're looking more at approaches that you might use in a therapy session, psychoeducation is the number one strategy that seems to be extremely effective for bipolar patients. Psychoeducation here means basically educating the patient about their illness, and especially so that they can watch for early signs of relapse, make sure they take their meds, and find coping strategies that will work for them. Cognitive behavioral therapy is another strong recommendation. Due to a lot of the issues that come up with bipolar, there's a lot of negative thoughts that arise. So CBT can help identify and challenge those thoughts. Another one would be family-focused treatment, which is involving family members and caregivers. The goal of this is to improve communication and decrease stressors that are going to trigger relapses or episodes. And then lastly, interpersonal and social rhythm therapy, which helps to regulate daily routines and establish regular sleep-wake cycles. And these are our references.
Yeah, we provide a select list of references. But it's been a pleasure presenting to you. Thank you.